Hello, and thank you for joining me. I appreciate your time. My name is Matt Walker. Since 2016, I've been the Executive Director and Registered Lobbyist for the West Virginia Independent Pharmacy Association. The group is a nonprofit association that represents the interests of independent community pharmacies and patients in the Mountain State. As a small rural state with tight-knit communities, West Virginia has one of the strongest networks of independent community pharmacies in the country, with locally owned and operated pharmacies found in almost every small town and community. For a list of members, please visit the WVIPA's official website. For the next few minutes, I'll talk to you about West Virginia's Pharmacy Audit Integrity Act, which is a fairly new and evolving law in the West Virginia Code that regulates pharmacy benefit managers, commonly referred to as PBMs. The goal of the law is to protect pharmacies and their patients. It was first signed into law in 2017, with updates each year since then. Thankfully, West Virginia Governor Jim Justice signed each bill into law following overwhelming support from the legislature in both the House and the Senate. Our elected representatives understand the challenges that PBMs pose and have stepped up time and time again, year after year, to protect pharmacies and patients. I urge you to dive in and read the law to better understand it. And if you are a pharmacy owner or a pharmacist, I urge you to join the WVIPA as a member. If you are an employer health plan sponsor or patient, I urge you to contact the WVIPA. We are glad to explain to you how the law applies to you and your business, to your employees, to your family, and to your friends. Our goal with this video is to facilitate conversations and provide resources and support. Since it became law, the Pharmacy Audit Integrity Act has grown into a sort of Bill of Rights for pharmacies and patients. Think of it as a law that protects your medicine, where, how, and when you get your prescriptions, how they are paid for, and details like that. The healthcare system is already complicated, and pharmacy issues are some of the most complex issues discussed. They are also some of the most expensive. Almost every health plan in America will tell you that prescription drug spending is their #1 spending item, yet prescription drugs are the least understood parts of most plans. Such an important issue deserves more investigation, transparency, and a clear explanation. That's what the WVIPA is here for. I hope this discussion brings clarity to West Virginia's laws. I also hope this video is simple and clear enough to help people who are not experienced in a pharmacy setting, who don't know much about PBMs, and who may not often think about their prescription drug coverage until they can't access their medication or until they find themselves with an expensive, overwhelming bill. If you have any type of insurance coverage, such as a fully insured commercial insurance plan, Medicare or Medicaid benefits, a state health plan like West Virginia's Public Employees Insurance Agency, or an employer-sponsored plan that covers you through your job, often called an ERISA plan, you probably have a PBM that processes and manages your pharmacy benefits. ERISA stands for Employee Retirement Income Security Act of 1974. If you are a pharmacy owner, a pharmacist, a pharmacy tech, or another type of healthcare provider, your ability to educate and assist your patients depends on your knowledge about this complex system. As we dive into the details of the Act, I'll provide a brief history of pharmacy and PBM regulation in West Virginia. In 2016, no PBM regulation or oversight existed in West Virginia, although PBMs already controlled a vast majority of the prescriptions being dispensed to West Virginians, about 80% or more. PBM misconduct was rampant, with pharmacies and patients suffering in terms of access to medicine and financially, as PBMs quietly became some of the most profitable companies in healthcare. In fact, they became some of the most profitable companies in the world. The 3 largest PBMs and their insurance company partners are now among the top 12 largest companies in the United States. You heard that right. 3 PBMs are at the top of the Fortune 500. In 2016, the West Virginia Independent Pharmacy Association was created by a group of pharmacy owners determined to protect their pharmacies and patients from PBMs. In 2017, the Pharmacy Audit Integrity Act was passed by the legislature as Senate Bill 522 and was signed into law by Governor Jim Justice. It can be found in West Virginia Code Section 33-51, along with West Virginia's other insurance laws. Although the law wasn't perfect and it fell short of providing the protections that pharmacists and patients were seeking, It was a solid start, creating a registry for PBMs under the West Virginia Offices of the Insurance Commissioner. It also protected pharmacies from predatory PBM audits by creating a clear and equitable audit process. Before this law, PBMs could audit pharmacies in any amount, at any time, without notice or transparency. This led to frustration on behalf of pharmacies, with audits often targeting high-priced drugs and leading to large reimbursement recoupments, even for simple typos or signature mistakes that didn't impact the PBM or patient in any meaningful way. In 2018, Senate Bill 46 eliminated gag clauses, which were used by PBMs to prohibit pharmacists from telling their patients when they could buy drugs less expensively for cash than by using their insurance. These gag clauses also prohibited disclosure of other information about lower-cost alternatives that would benefit patients. If PBMs act in the best interest of patients as they claim to, why would they prohibit pharmacists from educating their patients about the cost of their medicines? It was at this time that legislators in West Virginia truly realized PBMs do not act in the best interest of patients and even their health plan sponsors at times. PBMs act in the best interest of their own shareholders and their own bottom lines every time. The bill also required PBMs to itemize and describe the fees that they charge to pharmacies. These fees are sometimes referred to as clawbacks, DIR fees, and other terms. No matter what you call it, these fees are simply PBMs pickpocketing hard-working pharmacies without transparency. Imagine completing a transaction at the point of a sale in a pharmacy, dispensing a medicine to a patient, and then having the PBM change the terms of the deal later, clawing back thousands of dollars each month with no remedy or appeal. Even more outrageously, PBMs sent pharmacies and patients cease and desist letters if they discussed these issues with patients or regulators. I'll give you an example. If a patient presented a prescription at a pharmacy and the cost to the patient was a $20 copay when using their insurance and a PBM to process the claim, but the same drug could be purchased with cash for $10, the pharmacist was not allowed to tell the patient about that $10 savings per the PBM contract. In 2019, Senate Bill 489 changed everything, and for the better. This new law required PBMs to become licensed to do business in West Virginia by the offices of the Insurance Commissioner, bringing true regulatory oversight to this multi-billion-dollar industry. Senate Bill 489 mandates that PBMs may not require prescriptions to be dispensed and delivered to patients via mail order, but that option will always be available. And that PBM pharmacy networks must include brick-and-mortar pharmacies, not only mail-order pharmacies. Patients in West Virginia trust their local pharmacists and should be allowed to see them to receive counseling when filling a prescription. PBM pharmacy network reports must be submitted to the OIC annually. Violations of the Act can result in fines, penalties, and even a revocation of a PBM license to do business in the Mountain State. The new law also included important 340B drug pricing program protections, providing discriminatory reimbursement protections for 340B covered entities, which includes West Virginia's safety net hospitals and community health centers. These providers provide services to all West Virginians regardless of ability to pay. Finally, Senate Bill 489 mandated transparency reporting for PEIA's pharmacy program, an important first step toward fixing the broken system that PEIA still uses to process pharmacy benefits today. One quick note that will surface again later. This new law included an ERISA exemption, meaning the Act would not apply to ERISA health plans, which are employer and union-sponsored health plans. This was purposefully preserved while an important case was being considered by the U.S. Supreme Court. Spoiler alert, pharmacies and patients won in a unanimous Supreme Court decision in December of 2020. In 2020, the legislature passed House Bill 4058, with the WVOIC continuing to promulgate legislative rules to carry out the intent of the Pharmacy Audit Integrity Act, including a $1,000 minimum and a $10,000 maximum fine against PBMs per violation of the Act. This means a PBM could be fined as much as $10,000 each time they violate the Act. That's per prescription. The OIC also provided a simple online consumer complaint form, which can be found on their official website. I'm urging you, as patients and pharmacies, to send in complaints to the OIC if a PBM violates the Act. Also in 2020, the ERISA exemption was removed from the Act, meaning the act was intended to apply to ERISA health plans. This has been the source of some confusion thus far, but in the opinion of the OIC, as evidenced by formal bulletin releases, the Act does apply to ERISA plans in terms of reimbursement, consumer pharmacy choice, and other instances. In 2021, House Bill 2263 became the envy of pharmacies and patients nationwide, making the Pharmacy Audit Integrity Act one of the nation's strongest pharmacy laws. This law established the national average drug acquisition cost, also called NADAC, plus a $10.49 professional dispensing fee as the reimbursement floor for dispensed prescriptions in West Virginia. This mirrored what West Virginia Medicaid adopted several years prior, back in 2017, using actual acquisition cost as the basis for its reimbursement methodology. Remember, NADAC is a benchmark developed by consistently surveying retail community pharmacies across the country, collecting data on outpatient drug ingredient costs. It's been around since 2013 and is often updated on a weekly basis. A quick note, if NADAC is not available for a drug, the law calls for wholesale acquisition cost, also known as WAC, to be the reimbursement methodology. PBMs and insurance companies may claim that increased dispensing fees are the driver of higher pharmacy costs, but this is a red herring. The real drivers of higher pharmacy costs are PBMs and their spread pricing tactics, which means charging a health plan more for a drug than the pharmacy is paid. If your company has a health plan, ask your PBM if your health plan is being charged the same amount for your drugs that the pharmacy is being paid. If not, your plan is being taken advantage of. Recent data shows that PBMs spread price some drugs hundreds or even thousands of percentage points. And when it comes to dispensing fees, national analysis shows that dispensing a prescription costs around $14 per transaction. Pharmacies should be paid fairly for their services and never below cost. The bill also included a freedom of consumer choice of pharmacy provision, also known as an any willing pharmacy provision, that requires PBM networks to provide for convenient patient access within a reasonable distance from a residence, and affords pharmacies an opportunity to participate in pharmacy networks. Basically, a PBM cannot prohibit or limit a patient's choice of pharmacy in West Virginia. They also cannot impose a copay, fee, or condition that's not equally imposed on all beneficiaries under the plan. Basically, a PBM cannot use a financial barrier or promotion to steer a patient to the pharmacy that they want. This is the patient's choice, all the time. Also, a PBM may not reimburse itself or an affiliate pharmacy more than other pharmacies, as that would be an unfair competitive advantage. Finally, the bill included a nationwide, first-of-its-kind drug manufacturer rebate shared savings provision that requires 100% of drug manufacturer rebates, which are often not disclosed to health plans, pharmacies, or patients. They must be calculated and passed through to patients at the point of sale to reduce the patient's cost sharing. For patients, this does not mean you will ever see cash back at the pharmacy counter, but it does mean your cost sharing should be reduced by the full amount of the drug rebate. The way the law is written, this won't apply to copays, but it will apply to deductibles and coinsurance. Excess drug rebates may be collected by health plans to reduce premiums, and the West Virginia offices of the Insurance Commissioner must oversee this process to make sure that happens. The law and rule contains a specific provision to hold patients and pharmacies harmless for miscalculations made during that process. To West Virginia employers and HR benefits professionals, you may be hearing from PBMs that West Virginia's pharmacy laws will increase your costs. My plea to you is to dig into the details of your health plan and don't take what these PBMs say as gospel. There is a high likelihood that your PBM is using spread pricing and is skimming drug rebates from your health plan, costing your business money. They are not saving your plan money, they are costing your plan money. They are not doing what's best for employees, they are taking advantage of your employees and limiting their access to medicines and the pharmacy of choice. Contact the West Virginia Independent Pharmacy Association. We'll assist you with finding a PBM that will always act in the best interest of your plan and your employees. There are options, often called transparent PBMs, pass-through PBMs, fiduciary PBMs, and fee-only PBMs. Remember, West Virginia pharmacies are businesses too. They understand your issues as employers. Their health plans also want to pay less for drugs and secure better benefits for their employees. In 2022, House Bill 4112 refined the definition of healthcare payer to make clear which health plans the Pharmacy Audit Integrity Act applies to. Remember, this follows years of court battles in various states, as well as the unanimous Rutledge v. PCMA decision by the U.S. Supreme Court. Because of this change, some provisions of the Act are not being applied until January 1st of 2023 to avoid impacting certain ERISA plans mid-year. However, on January 1st of 2023, provisions of the Act will apply to ERISA plans, specifically the reimbursement and consumer choice provisions. Another important issue: in recent years, PBMs have limited access to expensive, limited distribution drugs by designating them as specialty drugs. Over the past decade, the number of drugs designated as specialty and the spending associated with these drugs has skyrocketed. Again, a specialty designation means these drugs can only be accessed by certain pharmacies, all dictated by PBMs, not dictated by patients and their providers. This law defines specialty drug for the first time ever in West Virginia as a drug used to treat chronic and complex or rare medical conditions and requiring special handling or administration, provider care coordination, or patient education that cannot be provided by a non-specialty pharmacy or pharmacist. Please note that the definition is not driven by cost, which is what drives PBM definitions of specialty drugs. The bill also creates an appeal process for patients and pharmacies who wish to challenge a PBM's classification of a drug as specialty. The process will involve the OIC and the West Virginia Board of Pharmacy, the real experts on prescription drugs. These two groups will make a formal determination about a drug based on clinical and therapeutic considerations. The bill also mandates that PBMs must give pharmacists at least 30 business days notice in the event of a contract or provider manual amendment. Over the past several years, PBMs have become notorious for amending these documents unilaterally with no discussions or notice afforded to patients or pharmacies. So in summary, when analyzing West Virginia's Pharmacy Audit Integrity Act, it may be helpful to put the different sections of the law into buckets with practical real-life examples. Bucket 1. PBMs are now licensed and regulated in West Virginia. Billions of dollars are spent on pharmacy in the Mountain State, so some level of oversight is appropriate. Bucket number 2. Consumer and patient choice of pharmacy and access to affordable medications must be protected in West Virginia. West Virginia Governor Jim Justice and the Republican supermajorities found in both the House and the Senate clearly agree. Patients must be allowed to choose the drugs they want at the pharmacy they want. Anything contrary to that will not be tolerated in the Mountain State. Bucket number 3. Pharmacies must be reimbursed fairly, meaning paid at least at cost for a drug's ingredient cost plus a fair professional dispensing fee. This is not negotiable, and West Virginians overwhelmingly agree on this point. Bucket number 4. Pharmacies and patients must not be tricked, nickeled and dimed, or mistreated after the point of sale, i.e. when a drug is paid for and dispensed to the patient. Any fees, rebates, and other financial elements must be made clear at the pharmacy counter and must not change later. Again, thank you for your time. That's a lot of information to digest, and please know that if you're a pharmacist, a patient, or a plan sponsor in West Virginia, the West Virginia Independent Pharmacy Association is here for you to support you.